agenda? Because I'm not sure if it's up.
I can see it.
Okay.
Yeah.
Perfect. Okay. So welcome everybody to the 21-22 season of REMSCO REMAC baseball. So again, I would have been nice to see everybody in person, but obviously that's not doable right now. So we will continue with Zoom. As you mentioned before we went live, this is currently extended through January, and we will have to reevaluate going forward if we will be able to do this after January. So to start with, what we'll do is we're going to do a REMAC roll call to establish if we have a quorum. If we do not have a quorum, we cannot vote on anything. We can discuss it if people choose to, but we will not be able to vote. So I will open up the question as to whether or not we want to discuss it and vote at a later date or hold the meeting at a later date. But let's start with establishing whether or not we have a quorum. So Marie, why don't we start with the REMAC, and then we'll do medical standards after that.
Okay.
Hey, yay.
Precisely.
Okay. Please answer when I call your name. Grace Cacciola.
Good evening here.
Hi, Grace. Glenn Asada, was he able to get in?
Yes, I was. Thank you.
Thanks. Brad is not here tonight.
Yes, and one of our fellows is covering for him. Which one, Dan or
I'll be
Nick?
Dr. Benelli. Nice to meet you,
Okay.
Marie. Pleasure to be with you all. I'll be
Hi.
representing Greg Hoffman.
Oh, that's Nicholas.
Yes, Cozy.
Welcome. Dario Gonzalez,
Here.
Nathan Reisman. Reisman.
Reisman?
Sorry, it's New Year. I have to remember again. Reisman. No? Yes?
Here.
He's here. He's here.
Pam Lai,
Here.
Nick Alexandru.
I'm here. Hi, Marie.
Hi. And Doug is not here. There's an alternate for him also.
Yeah, Dan is covering for him.
Hey, Mary, I'll be covering for Doug tonight.
Daniel Schwartz.
Oh,
Daniel Schwartz.
sorry, I'm not spelling everything right, but I guess that's close enough. Oh, no, that goes here. Kevin Ward,
Here.
hey Kevin.
How are you?
Anne-Marie Grigenti, Samia McKeechin,
Present.
welcome. Jeffrey Raybridge, Dr. Raybridge, Reed Caldwell, Jonathan Berkowitz, Lewis Marshall, Michael Red, I'm sorry?
It's to the closing bell. So let's introduce you to the two people in the stream who are going to help us get there along with Sean and me. George C.
Somebody needs to mute themselves. Michael Redlener. We may not have a quorum. Dominic Battinelli. Efren Rendon. Joseph Schenker.
Here.
Michael Vatch. Robert Ackerman. Joseph Bove.
Present.
Sean Graves. Arthur Cooper. Robert Winchell. Ed Jarvis. Mark Cantor.
Ed is here. I've seen
Ed's
Ed here.
here.
Yeah.
Okay, Ed Jarvis. Mark
It's
Cantor.
here.
Robert Krupe. Tim Stiles.
Present.
Whoa. Laura Ivacoli. Stuart
He's here as
Tesla.
well.
I'm here. Sorry, I couldn't get the mute.
That's okay. I know those mute buttons. Matthew Fink or Wallace Carter. Matthew Fink or Wallace Carter. Eric Cohen. Kevin Munjal. Cindy Basilios. Maria Bodick. Matthew Harris.
I'm here, Marie.
Okay, thank you. Jessica Van Voorhees. Ben Zabar.
Here.
Paul Barbara.
Present.
David Benelli.
Representing myself, yes.
Peter Wire.
Here.
Yadidja Langsam.
Present.
Anthony Shalish. Okay, I'm going to do a quick count.
I don't think I count for a quorum in REMAC.
No, it's only the physicians for REMAC. That's one.
Is anybody here that was not called during the roll call?
Hey, Joe, it's John Berkowitz.
Doesn't sound like John. It might be an imposter.
We're just waiting for Marie to tabulate the count.
We don't have a fellow who can stand in for John.
I think that'd be better off. We'd all
We
be
have
better off.
20. We have 20 physicians, so we have a.
What is the new total
Wait.
physician count?
Wait, hold on. I think I just counted wrong. 1, 2, 3.
Wow.
5. 9, 10, 11, 12, 13, 14, 15, 16, 17. We have 17 docs and the quorum is 17. So we just made it. No one can leave.
That's with the new count of docs, Marie?
We have 31 physician seats right now. Yeah, so that's.
Just making sure we're on the same page. Okay. Let's go through the medical standards. I'm sure there's going to be duplicates, but we just quickly have to go through it to, I think there's a few people here that are on medical standards and not on REMAC.
I'm sorry, you want me to go through medical standards now?
Yes, please.
We
Roll call
could
for
probably
medical
take
standards.
that count from the chat.
I think legally you need to do it orally. You can't take it from the chat.
Even though medical standards is not a statutory committee.
Well, then don't take roll call at all. But if you're taking roll call, it's got to be done on with a roll
All
call.
right, so Marie, let's do it quickly.
Okay. Nick Alexandru. Glenn Asada.
Here.
Marie, I'm here also. Nick Alexander.
Okay. Paul Barbara.
Here.
Jonathan Berkowitz.
Here.
Cindy Basilios. David Benelli.
Here.
Joseph Bove, Reed Caldwell,
Here. So we have to add Reed to REMAC as well. I think that he was not counted there.
yes. No, that was Dr. Bove, wasn't it?
That was me, yes, Marie.
Yeah, that wasn't Reed Caldwell.
Oh, okay.
Wally Carter, Neil Semilovic, Robert Krupe, Lauren Kosturko,
Here.
Dario Gonzalez,
Here.
Ed Jarvis, Dr. Jarvis, David Lobel, Matt Friedman, David Eng. Jeffrey Raybridge, Michael Redlener, Joseph Schenker,
Here.
Jason Zimmerman, Grace Cacciola,
Here.
Maddie Fong, Anne Marie Gregenzi, Sean Graves, Morty Lax.
Here.
Hi, Morty. Long time no see.
Hey.
Bad summer, huh? Michael Vatch or Robert Ackerman, Kevin Ward,
Here.
Art Cooper, Dr. Langsam,
Present.
Louis Marshall, Kevin Munjal, Jessica Van Voorhees. Okay, so medical standards, attendance is taken. 1, 2, 3, 4, 5, 6, 7, 8, 9. Yeah, we definitely don't have a quorum for medical standards, but we have enough for REMAC, so we can go forward.
All right, so what we'll do is we'll go through the we're gonna go through the REMAC agenda. We will break away when we do the medical standards components. We will do those, discuss them, have a joint discussion, and then a vote in order to expedite this from a time perspective. Marie, you said there was no correspondence?
No.
Okay. And David, did you want to introduce the fellows as part of a correspondence?
Yes, so we have, I'm very proud and happy to introduce our 2 new EMS fellows who replaced last year's fellows. They started on July 1st. It's Daniel Schwartz and Nicholas Cozy. We're very happy to have you here. And we expect greatness. Thank you.
Amen. Okay. So the executive committee has not met since our last meeting, so I will skip that report. I'm just going to skip the subcommittees briefly. Was there a regional council update? Regional council did meet?
Yes, it's very quick. There were 3 applications of transfer of operating authority which were approved: ACE to AMR, Hunter Ambulance to AMR, and Hunter EMS to AMR. There was 1 application of determination of public need which was denied. That was the expansion of an existing ambulance agency of Bay Community Volunteer Ambulance. That was denied. And there was a reappointment of 1 at-large seat, Dennis Laurie. And that was the end of the meeting. I'm done.
Excellent. Thank you. Any questions for you, did you? Okay, CMAC did not meet. And let's go to subcommittee reports. We'll start with Dr. Barbara and CNC. Any discussions at the medical standards level we'll have, and then we will, if there's any action items, we'll vote on them at that time.
Charlie, can you throw that up or no?
No, I do not have that.
Okay, so I'm just gonna put this up real quick. Hopefully this is just my PowerPoint and nothing else. You guys aren't seeing my emails, right?
That is correct.
Okay, so just a credentialing update. We started a new process in April with a bunch of forms and a lot of complexity to try and streamline the process. Just from April to 2021 to current, we have 46 people who have gone through the exam with the 2021 protocols. The average score is 52 out of 55 for a whopping 95% pass rate on a written exam. The bulk of providers are coming from some of our known course locations. But in the first quarter of this, it's mostly a lot of research and people who, going through the June to July add-on. This is just a quick snapshot, and this is an output of how the test questions perform. Without seeing the text of the questions, I'd just like everyone to draw the attention to essentially that none of these questions are discriminatory. Everyone's getting the same answers every time. Someone else needs to mute? Well, I don't know. We have a couple of questions that, draw attention. Maybe it's a poorly written question. It's one down in the middle column on the right. There are definitely some different choices, but from a test taking strategy, the questions we ask are either, people are demonstrating competence or the test itself is an exercise in futility. The questions I have about, with this type of objective material is this the best model for credentialing physicians? Are we demonstrating that these students who have gone through this process are proficient in medical decision making? If this exam is needed, how can we improve it? Quality piece, obviously, and then really key point is all the work being done at protocol committee is how do we distribute that work? How do we keep people updated? Basically, that's the sum total report from the medical control piece. I want to turn over to Mr. Ward for the remainder of the CNC committee report, but I just want to ask anyone questions about this first.
Paul, can you put those questions back up that you just had?
Sure. Oh boy. Is that correct? Okay.
Yeah, that's perfect. No, not that. Those questions that you had, those on the blue.
Oh,
there.
those. Okay, I apologize. Wrong.
I just wanted to open any discussion about these specific questions and what do people feel about the exam and the purpose for the exam and so on. I think that, it is an open book exam. The purpose of it has always been to ensure that the physicians operating in this region do review the protocols and have an understanding of basic EMS oversight. It is not designed to make medical directors. It is not designed to make, the be all and end all of EMS physicians. Any questions or any discussion on these questions in particular that Paul raised as good talking points?
I think we're one of the only regions in the state that has an entrance criteria. Right.
I don't know, but I think that it's still something that I personally think it's necessary that people at least know what our protocols say. We're not doing the same thing as the rest of the state. If somebody here feels otherwise or feels that maybe it's something that is in excess, we can always discuss how we can approach it. What does everybody here think?
I just want to point out that using the argument of we being one of the few regions in the state, we are one of the few regions in the state that make the medics take an exam like this every 3 years. So I don't think that's a good comparison. I think we do what we know New York is better than New York City is better than everywhere else, and we should do what we think is best for our region.
I believe also that Westchester has a test.
Nassau
But
does,
John
I
Bur-
know that.
Yeah,
Did I say
John Berkowitz,
did I say
correct me
something
if I'm wrong.
false about the regions of the state though?
Oh, I know that Nassau has a medical director exam.
Mhm.
I
It's
believe.
the paramedic exam.
Okay, that doesn't
No,
mean.
I'm just saying we are one of the
Okay.
only regions of the state that does this. I didn't say anything. If I'm false in my statement, I'd like,
I don't think so. I don't know.
proof.
John,
You can
John
interpret it the same way
Berkowitz,
you
can
want.
you?
Yeah,
John Berkowitz.
Westchester. Yeah, Westchester has a different exam for the physicians than for the paramedics, but there is an exam that's required to take, and you have to be matched to provide medical control.
Okay. Any other discussion on this? Does anybody think that we shouldn't be doing it? All right, hearing none and no motions, I think we'll move forward. Marie, can you put the agenda back? David, you're muted.
I'm sorry. I believe Kevin Ward also has a presentation for CMC.
Yeah, like Kevin. Yeah.
Go ahead, Kevin.
Not a presentation per se, just testing remains ongoing. We're in the process of updating the exam to reflect the protocols that will be going into effect. We don't have a thorough breakdown of the current exam because the exam itself was so short-lived, a quick turnaround between, it going into effect and rewriting. I can tell you that the pass rate teeters around 80% for first try. CNC, I'm going to be making we haven't met over the summer. I'm going to be making the calendar, and that will be going out probably tomorrow. We'll be meeting monthly, so we should have a CNC report by the next REMAC meeting. And that's really all I have.
Yeah, I just want to remind everyone that, as the protocol changes occur, the questions require updating as well.
Right.
So in the interim of rapid protocol changes back-to-back years, it's tough to really judge the test because we're scurrying to keep it updated so that we don't have anecdotal inaccuracies, that people are going to create,
we're in the middle right now of evaluating
concerns.
which questions need to be pulled versus which questions just need to be reworded, to reflect the upcoming changes.
So any examination of the test itself has to both wait for the protocol changes in mass to stop and also allow for us time to assess, the question. So most of our bandwidth is going to be spent keeping the test up to date with the protocols as they've been changed. Thank you.
Okay. I think protocol is going to take the most amount of time. I want to just touch base on a few of these other subcommittees, and then we'll get back to protocol and medical standards. So let's do QA and then T&E, and then we'll shift over to medical standard. Actually, and then RTAC, and then we'll shift to medical standards. So QA, Joe. Is Joe Ranieri here? Saw him before.
I don't believe Joe Ranieri is online right now.
Okay. And I know that the last meeting was supposed to be yesterday, but 2 days ago, but got canceled.
Mm-hmm.
So I'm going to, let's table this QA report to the next meeting. T&E, Morty?
Doesn't have a lot to report. We received, thanks to Pam, a lot of material so we can keep everything regionalized. So we're going to be working with the material provided to us by the fire department that they're going to be using for their training to do something similar to the last time around where we can regionalize the training and for the protocol update, that is. And other than that, there was a successful, very successful actually, certified instructor update class recently that was hosted by BMCC. So thanks to them. And that's all we got for now.
Thank you. Okay, RTAC, and then we're going to go to medical standards. Is there anybody here from RTAC to give this report? I don't see anyone.
No, Dr. Berry was not able to be here tonight.
Okay, so we'll table this to the next meeting as well. And that brings us to Dr. Benelli and medical standards, including the interfacility tag. So, Dr. Benelli.
Okay, very good. I don't know if we, Marie, did we send out the minutes from the last meeting, the joint meeting for everyone? Marie? Marie, are you there? Okay,
Sorry,
I don't know.
Someone trying to get into the meeting and I don't know how to get them in, so.
I'm not sure you're a host. Charlie can let them in.
That's right. I'll have to get back to you, Pace. Like, I don't know if I can get you in right now. Okay, I have to go back to the meeting.
Marie, did we send out the minutes for the last meeting for the last joint REMAC and medical standards meeting?
I thought I did. I definitely have them.
Okay, well, we won't vote on, yeah, maybe we'll vote on them next meeting then, because I don't believe I saw them. So I think that we already, CNC already gave their report. I think we'll, why don't we leave protocol to last? The interfacility committee tag, the interfacility tag with Dr. Berkowitz.
Marie,
would you like to?
Marie, your email is open on the screen.
Whoops.
Would you like to?
That so many times.
Okay, Dr. Berkowitz, do you want to give an update?
Absolutely. So we met, I don't remember the last date that we met. I think it was early August. We have to set up the next one, but we discussed education and credentialing, focusing on kind of what the recommendations are for credentialing, what the recommendations are for specifically in related to equipment, and made a bunch of recommendations regarding how the education for equipment should proceed, and how crews need to essentially be trained on the equipment they're being asked to move. We also had a similar discussion regarding medications and education regarding medications used in facility, and lastly, continuing education. I have notes here and kind of a list of the standards that we're working on. I'm gonna send out probably before the next meeting. The next meeting, we're going to talk about protocols and define minimum standards for that. Remember, there, as a reminder to everyone, there's essentially 6 segments of this project to develop minimum standards for IFT. The first segment is level of care and scope of practice. The second segment is education and credentialing. The third segment is protocols and procedures. The fourth segment is medical direction. The fifth segment is quality, and the sixth segment is operations and communications. So that's my update. I'll talk to Marie to figure out when the next meeting will be, because I think that we're due to have one probably soon.
Yeah, I don't have a meeting scheduled for you, so let's, after this meeting, maybe tomorrow, we'll sit down and do a 6-month worth of meeting dates.
That would be perfect. And then hopefully by the last meeting, 6 months, that means we'd hopefully be almost done with this this manuscript.
Okay.
All right, thank you.
Any questions?
Okay, thank you very much. Any questions for Dr. Berkowitz? Very good. The ECMO tag, I'm just going to give a very short update. Currently, we're still in the process of recruiting hospitals to, as you may recall, we're talking about starting a short time limited pilot in Manhattan. So far, we have 3 hospitals on board, and that's Bellevue, Mount Sinai, and most recently NYU, thanks to the help of Dr. Caldwell. We are still trying to get New York Presbyterian on board. Other than that, we have a preliminary protocol that the TAG has been working on. I don't think we should present it right now. A preliminary protocol that needs further refinement, but it's a foundation to build on. In addition to that, we have to try and meet and see if we can get some muster up some interest regarding to project management for this. And that is something that Dr. Kaufman, Dr. Redliner, and myself have to do. That's just about it for now. I don't think that, I think we'll have much more information when, towards the October meeting of Medical Standards and REMAC. Any questions? Very good. I think that, is there any old business or any new business that anyone wants to bring up before we go to the protocol committee meeting? Okay, hearing none, Dr. Lai, please present the protocol meeting and we'll move from there.
Great, so I'm just going to share my screen. So protocol committee met on September 3rd to discuss, both basically two protocols, both the FDNY hashtag protocols as well as the FDNY rescue paramedic protocols. David, I'll have you kind of introduce the hashtag protocols.
Sure, 1 second. Okay, very good. So you're pulling, so the hashtag EMT and paramedic protocols are essentially the hashtag, just for those who are less familiar, the hashtag battalion provides the medical component to the hazmat, to the fire department hazmat battalion, and they are trained to deal with any hazardous material exposure. For that purpose, we've been working for a very long time. We've been working for a very long time. We worked for a very long time on creating protocols. They were approved initially, I think, in 2015 or 2016, and they include different components to how to approach and how to deal with and how to handle patients who are exposed to different hazardous materials. Following the initial creation of the protocols, there was an update that was also approved, and we felt now that we have a brand new set of new ALS and BLS general protocols in the region, we felt that there was a need to update the hashtag protocols to bring them to the same standard as that of our new protocols. And for that purpose, we went through again the hashtag protocols and created and updated it to the new standards that we have set for the whole region. Essentially, there is not much change in content with these hashtag protocols. And again, what's important to mention and what's important to stress is that what says on the top of the screen over there. These protocols are specialty unit protocols, and they only apply to EMTs and paramedics of the hashtag battalion. They don't apply to anyone else within New York City. So essentially, there's not much change in content. As a matter of fact, because our general protocols have been so nicely and thoroughly updated, many of the special protocols that we have had, many of the protocols that we have had in the HAZAC protocols as dedicated to hashtag EMTs and paramedics are not necessary anymore because they apply to the general paramedic and EMT population of New York City. And that starts with pain management and moves on with nausea and vomiting, et cetera, et cetera. So as a matter of fact, the new protocols are actually smaller and slimmer and more concise compared to the prior set of protocols, because they contain, in many cases, they contain reference to the general protocols with a special emphasis on exposure to hazardous material. What has changed is that we have beefed up and made a much more robust initial management protocol, both for EMTs and paramedics. And that allowed us actually to minimize the other sub-protocols that talk specifically about exposures to specific substances, because if the management of bronchospasm is the same across a number of protocols, there's no need to repeat it because it's already mentioned in the initial management. The second change that has been made is in the organophosphate protocol, and in the organophosphate protocol, essentially it mirrors the weapons of mass destruction protocol of the general New York City REMAC protocols. However, we are allowed to only use the weapons of mass destruction protocol when a class order is issued, and that is by an OMA physician for 5 patients and above. There is kind of a loophole over here where if there's a singular organophosphate exposure, for instance, by suicide in India, it has been popular in the past to try to commit suicide with pesticide, then we would not be able to use the weapons of mass destruction protocol to treat such patients. For that purpose, we created this protocol over here where it says that with an OMA physician approval, you can treat under the weapons of mass destruction protocol certain patients, even if we don't meet the criteria for a class order. And this again is limited only to hashtag EMTs and paramedics. The same loophole exists also for the cyanide exposure protocol. Again, if it's if the exposure is Pam, it's up, not down. It's backwards. The same loophole exists regarding if cyanide is used as a weapon of mass destruction, then again you need a class order for that. Of course, if cyanide exposure is from from combustion from a fire, then you can still treat in less than 5 patients. But again, in the instance that there is weapons of mass destruction with use of cyanide for less than 5 patients, then we could not use the protocol, the general REMAC protocol, and this kind of corrects that loophole and allows hashtag EMTs and paramedic to treat with the cyanide protocol for less than in a situation where that does not meet criteria for a class order. Other than that, there really is not much change. The protocols are smaller, less for our paramedics and EMTs to remember, which is always good. I'll entertain any questions. Good. So Pam, let's move on to the rescue protocols.
So wait,
Okay,
David,
Yes, go ahead.
all right, quick question. For cyanide exposure for a single individual, and for the other protocol for a single individual, why are these limited just to HAZTAC? Because I think that was not limited to just to HAZTAC. We had that in our
No, it's
protocol
limited.
as well.
It's limited to a class order.
No, that's the weapons of mass destruction protocol.
Yes, that is correct. And cyanide is not limited to it. You are correct. Cyanide exposure from any reason other than weapons of mass destruction, you can treat a single patient.
Right, but why if I remember correctly, and maybe I'm wrong, those are in the regular REMAC protocols. Why do we need a specific one here for HAZTAC different than the regular one?
Which one are you talking about?
Cyanide is an organophosphate. I don't know if we have organophosphate, but cyanide for sure.
Yes, organophosphate. Yes, organophosphate is treated under the weapons of mass destruction protocol. But again, it is limited to a class order. That's how the protocol is written, the general protocol. We wanted to cover a situation where there is a singular exposure that does not meet criteria for a class order and allow our EMTs and paramedics treat these patients.
Correct, but I guess my question is, why is that only limited to the HAZTAC battalion? Because cyanide exposure for a single patient.
Because we anticipate that there will be heavy HAZTAC involvement, including a HAZTAC officer on scene.
Not for a single patient.
Not necessarily. So for a single patient that meets the criteria and a HAZTAC officer believes that we need to, that this meets the criteria, then we would get.
I guess my point is that this might happen to a non-FDNY, non-HAZTAC unit would be exposed
Absolutely.
to a single
And
patient.
then,
Why would it
absolutely.
be- but this protocol doesn't apply to them.
Well, that does not apply to them. If there is a concern for an exposure, then they should definitely get hazmat involved. The situation is
cyanide is under the regular protocols. We already have a protocol for cyanide exposure for a single patient.
We do for fires, definitely.
But
We are talking about.
isn't this redundant? Is my question.
I don't think it makes
Under a class order, it's not, right? Because that's just fire is in charge. It's an MCI. There's a class order. 100% that makes sense. But a single patient with a cyanide exposure or a single guy in a flower shop using pesticides who gets an organophosphate exposure, it might not trigger a HAZTAC response. And the first unit on scene should be able to manage those under the regular protocols.
Well, I don't think that we, I think that at this point, if there is a concern for any even pesticide, if there is a question whether this is weapons of mass destruction or not, I think that the hazardous material battalion should get involved and should assess that. And then once that happens, once hazmat is involved, and then we allow our EMTs and medics that are trained with hazmat exposure to take care of these patients. That is, since this is the only reason why, because with the way the current protocols are written, it is not permitted for our regular line paramedics. This kind of helps address that situation where there is no class order, where we do not meet criteria for a class order. So that's why we felt that it's better to close the loophole and leave an option, not like every medic or if every EMT should start treating it, but at least our hazmat battalion would be able to get involved and decide whether we need to treat these patients or not.
Okay.
But you do have a BLS protocol, which I'm looking at, which says cyanide exposure, adult and pediatric.
That is correct. And that protocol, if you read the details, if you read the wording, it talks about treating singular patients for a cyanide exposure from a fire. But if there is a concern, yes, Edita. If there's a concern for weapons of mass destruction, then you need a class order in order to do that.
That's correct. But it's not only for a fire. It says if there's a fire, then you call Finley. But what happens if it's a lab, a chemistry lab in a college?
Yes, then Finley should be called as well because this is a hazardous material exposure.
So what I would suggest is that the HAZTAC battalion protocols are when there is a hazardous material incident and the HAZTAC battalion is deployed. For a singular patient, the chances that a unit that is not in the HAZTAC battalion might be at that scene with a single patient that can be managed initially by a single provider if they recognize the signs and symptoms of organophosphate toxicity or the signs and symptoms of cyanide poisoning, that maybe is already addressed in our basic protocols and doesn't necessarily wait until there is a HAZTAC battalion on scene. That's my only question. It would seem to me like a singular patient there is many more people than the HAZTAC battalion that would be exposed to that singular patient. And I'm wondering if it's something we should consider under our regular protocols. We're not saying, as soon as it's a hazardous material incident with multiple patients, we all agree, HAZTAC battalion, deploy resources, and so on. But if you have a singular patient in, let's say, a flower shop who is having a reaction, should there be a method for the first medics on scene to administer atropine or a Supam if they have?
Joe, there is such a protocol right now because the cyanide protocol, I'm looking at it.
That's cyanide. That's different, right?
Yeah, but I'm talking about cyanide. I mean, we're talking.
I was talking about both. But my point is that
You got to
The
make it
cyanide
consistent.
protocol is what you're talking about right here, David. That's what we already have for
We're
sure.
talking, okay,
Right.
that is, yes. I mean, these protocols, as you said, Joe, I agree, and I agree with that differentiation, are meant for the hazardous material battalion. Okay, and
Correct.
once they are on scene, then we definitely need to allow them to operate. And
Correct.
there's no dispute about that. Whether we need to change our weapons of mass destruction protocol and change or update our cyanide protocol, that's something for discussion, and maybe it should be brought back to the protocol committee in the future.
Yeah.
But that's not something that should be addressed over here right now.
Well, again, I think that you're adding a singular patient to the HAZTAC protocol, which is already in existence in our regular protocols. It's
That is
redundant,
incorrect.
my only point.
That is incorrect. If you read the wording, first of all, it's for organophosphate and for weapons of mass destruction exposure of cyanide, the protocol does not allow you to take care of a singular patient. It's very simple.
So I just put up our current cyanide poisoning protocol. So this is just our regular protocol that I have up right now.
We have a
If we need this for
regular
reference.
protocol for cyanide exposure, adult and pediatric.
Yeah, Didier, read the criteria, please. The second sentence. A class order is required when operating
No, it
at a
doesn't say
scene
that.
with suspected. Yes, it does.
It does not. It
That's
doesn't.
okay.
Didier, look at the, okay, this is the new protocol that we all approved. A class order is required.
But if you have a single patient, that would not generate a class order.
Right.
Then again, this is
By
something we need to consider.
definition, weapons of mass destruction protocol is for multiple patients. That's in the beginning of the WMD protocols. For a single patient, this applies. If you have a single patient in a house fire who you're treating for cyanide,
nobody is disputing that. I agree. It applies.
but this patient
I
doesn't,
agree.
this doesn't talk about a fire. This just says a critical patient exposed to cyanide. WMD is 100%. I don't disagree with you, David. I'm just asking.
This is all. Yes, no, I agree. A critical patient exposed to cyanide. I agree. It's already there. Weapons of mass destruction patient. You know, something that's used, an intentional dispersal of cyanide as means to harm a lot. Hopefully not. But if I have two patients, then I can't use it under a class order. It's not a big deal, Joe.
Sure.
It's really not a big deal. It's not a big deal, and it just closes. It airs. It seals watertight the protocols.
I just think it's redundant. That's my only point. But if that's what we all want, that's fine. Anybody else have any questions about this? All right.
As a matter of fact, we actually canceled a couple of protocols again because we have a larger initial management protocol. Again, easier for medics and EMTs. Should we vote on this? Perhaps, I think so, right? Do we need to vote on them separately, Marie? Yedidia?
It's up to you and how you want to handle it. If there's no more discussion, and ask if anybody agrees, we can move on. If you want to do it individually, then you have to vote on each one.
Okay, any other questions with regard to the HAZTAC protocols? Yes. Okay. Having heard none, let's move on to the rescue protocols. Pam, I'll let you introduce those, and then we'll hold the vote on both of them, both for medical standards and for REMAC.
Okay, sure. So Doug does apologize for not being able to be here for this meeting, but he is unfortunately working clinically and is unable to present the rescue paramedic protocols. So again, just as what David has said, for the HAZTAC protocols, these are protocols that apply only to FDNY rescue paramedics and only while they are operating in a special operations environment. These protocols do not allow the rescue paramedics to use these on regular day-to-day jobs, but only when they are called in as a specialty resource in the special operations environment. In terms of the changes that were made to these protocols, they were mostly to just, It's like a whining dog here, but mostly these are to update the protocols in terms of for both the to reflect changes that were performed in our general pain management and our sedation protocols, and otherwise fundamentally there were no significant changes that were made to the protocols that were approved by REMAC and CMAC in 2018. So just to go through the changes, just to highlight them, because I know that REMAC unfortunately did not have a significant amount of time to be able to review these before the meeting. We did, just in the now times with COVID and everything else, we did add the half-face piece respirator onto our initial management as being something that our rescue paramedics are able to use to be able to protect the patient's airway from particulate matter during their operations. And then there were just like some minor language changes right here just for intravascular versus intravenous that was made before. Sorry for the headache-inducing scrolling that is going to be happening for a little bit. Again, there was just some minor language changes just in terms of the just the order of just the way that things were written that are just seen here in red, as well as we're using the language of using dextrose instead of D50 to better reflect potential supply shortages and everything, and also to be a little bit more consistent with our current REMAC protocols here for our compressive syndrome protocol. Otherwise, this was a, this part in terms of these medical control options that you'll see, these are actually just moved down to the section after the pediatric section. This was just sort of a confusing short point that we had done when we did the original protocols. That was just a little bit of a short side. So now that these are just kind of moved on to here onto this section, but otherwise these were not changed in terms of the medicine that was here. Moving forward, in terms of our environmental emergencies section. So again, like these protocols, just to remind the REMAC is for special operations environment and also for potential jobs where our paramedics may be operating in prolonged care situations. And that's why there is sort of like the need for a separate orders in terms of for the environmental emergencies, in terms of for the excessive shivering during cooling, that we have these options on here. These dosages are reflective in terms of the dosages that are in our current protocols. In terms of for midazolam as well as diazepam that was changed on here. And then also you will see this again, reflection and changes for our sedation protocol, as well as our pain management protocol. So again, these sedation and pain management protocols are going to be for those prolonged patient care situations. Again, dosing is changed, as well as sort of the language in terms of the repeat dosing, just to reflect the protocols that we have currently. We did add a repeat dose of ketamine, such that the maximum cumulative 2 doses can be administered by the rescue paramedics. This actually was just a short sight that happened during the first iteration of the protocols, and this is something that was actually caught by our providers. Again, in terms of procedural sedation and post-intubation sedation, dosing is actually just changed to have for our current protocols. And then for pain management, we had just some language on here just to keep it a little bit consistent, in particular with the morphine, where we're just like with our current protocols, we allowed them to have an initial maximum dose of 10 milligrams. Our providers in the prolonged field care type of situation, we will allow to have another dosing for them. Fentanyl dosing is again changed to reflect our current protocols. And then we did feel in terms of the ketamine dosing, this is purposely to be different than our current, than our regional protocols, as this was something that was discussed by Doug and myself, that these were dosing that we felt comfortable with for our providers to be able to administer safely to our patients. And I believe that is it in terms of the major changes that were done with the protocols. And again, do apologize that these protocols were not given. I don't believe that they were given in time in terms of for the committee to be able to review appropriately. But I went through the changes that we made for these protocols. Any questions for these protocols?
Hey, Pam, it's Matt. Can I make one comment?
Sure.
Sorry to interrupt. I forwarded to Doug, I received today some feedback from one of the pediatric pharmacists we talked to about the sodium bicarbonate dosing for compressive syndrome. I don't know if you want to wait on that facet of the protocol until you and Doug have had a chance to review it. There is a discrepancy, but I wanted to just make sure you guys were aware that I received it today. I apologize for the late delay.
Okay, I mean, I was going to say, like, I think at least for now, I think that, we will actually be updating these protocols. I believe probably sometime later, I guess like in 2022, we will be updating them because there will be some changes to our blood transfusion section. And again, that will, of course, then we'll need to have REMAC and CMAC approval. So I think that, in terms of for the sodium bicarbonate infusion that we have currently in our compressive syndrome protocol, Doug and I will review those. And I think that at least we want to make sure that we at least have our pain and sedation medication dosing to be consistent with our protocol rollout in January. And that was what our main focus on. I think that Matt, if it's okay with you, we'll have a discussion in terms of that sodium bicarbonate infusion that maybe that we can then incorporate into the new rollout with the updated blood transfusion protocol.
Absolutely. I just wanted to make sure you're aware.
Great. Thank you, Matt.
Thank you.
Pam, I just have a quick question.
Sure.
On these medications, are all these initial and secondary doses at the discretion of the rescue medics and the HAZTAC boss, or do they have to contact 5 Mary first?
So you'll see that there are that the rescue paramedic protocols, we do have a lot of these repeat dosing. We have a lot of these dosages that the paramedics are actually able to administer on their own understanding orders, if you will. There are some specific medical control options that I didn't really go through just because some of those were there since the 2018 reiteration of these protocols. But even for instance, even though, for example, we've only just recently with our new turnout of the protocols have airway management, sedation for airway management with allowed understanding orders for our regular paramedics. But as you'll notice in the rescue paramedic protocols, we've had these understanding orders as well as the inclusion of paralytics, since for a very long time, since before I've officially joined the fire department full time, so probably since at least like 2011, 2012. So that has not necessarily changed significantly with this new version of the protocols.
But the ketamine under pain management, that's a standing order?
That is standing order. That is correct. Any other questions?
Okay.
And ketamine's been there as a standing order for pain management for a while,
That
for
is
at least
correct.
5 years, 6 years.
Yeah, that is correct. Like our ketamine dosing has not changed since ketamine was first introduced in 2011, 2012.
Okay. Any further discussions regarding these two sets of protocols, the HAZTAC and the rescue protocols? And again, thank you to Dr. Harris for sending your comments. You both sent some comments also to HAZTAC protocols that were also addressed and incorporated. So I think that we will hold voting now, unless anyone has anything further to add. So for medical standards, it's just going to be simple. Is there anyone who opposes approving both protocols, the HAZTAC and the rescue protocols? Please let me know now. Is there anyone who's abstaining? Okay, Hearing not, we will assume that the rescue protocols that the HAZTAC and rescue protocols are moved as a seconded motion to REMAC for approval. And for that, we'll have to do, Marie, a roll call.
Okay. And this is to approve the HAZTAC and the rescue medic protocols?
That is correct.
So please answer in favor, oppose, or abstain. Glenn Asada. Everyone
Yes.
should unmute themselves.
Yes.
Somebody raised their hand, by the way. I don't know who that is.
Glenn.
I guess that's Glenn. Okay, fine.
Sorry, Marie, did you hear me? I don't know about these buttons. Yes, for me.
Okay, thank you, Glenn. Who was the alternate for Brad? That's Dr. Cozy?
That is correct.
Is supportive.
Okay. Okay. Dr. Gonzalez?
Support it.
Dr. Reisman?
Yes.
Dr. Lai?
Yes.
Dr. Alexandru?
Yes, in favor.
And Dr. Schwartz?
Yes, in favor.
Okay, Dr. Rabrich is not here. Dr. Berkowitz?
John?
Jonathan Berkowitz? Okay. Dr. Marshall? Dr. Redlener? I thought he was here now.
He had to step off. He'll hopefully be back.
And Dr. Schenker?
In favor.
Dr. Bove? Dr. Cooper? Dr. Jarvis?
I think Dr. Jarvis has had some audio issues.
Oh, I see. I see.
Connecting.
Dr. Jarvis, raise your hand if you're in favor. Thank you. Okay, so he raised his hand. Is Dr. Winchell here? No, okay. Dr. Cantor?
Yes.
Dr. Krupe?
In favor.
Thank you. Sorry, I couldn't answer your call earlier. Dr. Stiles? Timothy Stiles?
In favor.
Thank you. Okay. Dr. Ivacoli?
In favor.
Thank you.
Maria, I believe that Dr. Berkowitz can vote now.
John
Berkowitz.
Yeah, no, he definitely can vote if he's
I am here. Sorry, Marie.
No, it's okay. Oh, there you go. Okay, so you in favor?
Yes.
Okay. Is Dr. Bove back? Dr. Carter? Dr. Munjal?
Hi, sorry, I joined late. I'm gonna have to abstain. I haven't seen all the information. Apologies.
Okay. Dr. Basilios? Dr. Bodick? Dr. Harris?
Dr. Bodick is here.
Oh, okay.
In favor, Marie. Oh, sorry, Dr. Bodick, go ahead.
I am, yes. I'm sorry. I was having trouble unmuting. In favor.
Okay, great. Dr. Harris?
In favor as well, Marie.
Dr. Van Voorhees?
In favor.
Thank you. Dr. Zabar?
In favor.
Dr. Barbara?
He had to step off, Marie.
Oh, okay. Dr. Benelli
In favor.
and Dr. Wire.
Approved.
Thank you. Well, it looks like it's unanimous except for one abstention. 1, 2, 3.
If that's the case, the motion would pass. Actually, if we only had 17, it wouldn't.
Yeah, we have plenty. We have actually 21 people now that have voted. So
Great.
it's
Dr.
definitely
Benelli,
carried.
what's next?
Okay, thank you. Dr. Lai, I believe that there's one more item that's being brought from protocol for discussion at medical standards and REMAC.
Yes, thanks, David. Yeah, so just one more point of discussion. There's no forward motions that are coming from the protocol committee, but just wanted to bring this up since it was discussed at the protocol committee, just to get the REMAC members' opinions about this. I guess sort of in light of there being a lot more controversial discussion, I think, across the nation about ketamine use for EDP patients. In particular, you know, taking a look at sort of like the higher doses that are used currently for these patients. Just wanted to bring this to the REMAC committee, just in terms of you know, sort of like the safety profiles and everything else that are, you know, that are maybe concerning. I think that this is especially just like in light. I think that there were 2 paramedics, I believe, that were brought up on charges, I believe somewhere in Colorado in the Denver area recently for a patient, I believe, that was under their care that they had used ketamine for, that now that they were just sort of brought on charges. You know, the protocol committee, we didn't necessarily want to make this in terms of sort of like any sort of a reactionary, you know, changes or anything that were certainly made to our protocols. I do not believe that there have been any updated consensus statements or position statements that have been put forth by the American Medical Association, NAMSP, or ACEP. But this is just something that we just wanted to bring to discussion for REMAC.
Okay, any discussion? Thoughts?
Hi, everyone. I'm fairly new to this group, so I'm still learning. I'm Mira Boric. I'm the psychiatrist on the committee, and there is an official position statement from the American Psychiatric Association against the use of ketamine. Some of the arguments are because of the safety profile, but actually a lot of it is around the diagnosis and the stigma associated with how police is treating these folks. It's not specifically to how EMS is handling them. And ketamine is used in emergency settings in psychiatry as well. But there is an official statement from the American Psychiatric Association against the use of ketamine.
Dr. Bodick, if you could just send that out to the group, I think it would be helpful for all of us to see it.
Will do.
Thank you.
Any further discussion, thoughts for or against use of ketamine for these
David,
situations?
it's Matt. I'll just mention, having spent some time on the Denver REMAC equivalent, that the Denver Metro EMS group did put out a statement firmly against the banning on the use of ketamine, which is now officially banned in the state of Colorado, as sort of being reactionary to a single incident. And I think that you know, it seems like some of the pressure from the media has died down somewhat. I imagine that will pick up once the trial for these 2 officers and the 2 paramedics begin, if it gets that far. And I think, Pam, correct me if I'm wrong, but part of the conversation was whether or not there is a role to play, even prophylactically, as you know, the largest EMS agency in the country, to have a sort of a pre-prepared statement or a pre-prepared idea of how we would respond should there be a push to remove ketamine as a valuable tool in the pre-hospital setting.
Right, and that's why it's like, you know, I just wanted to bring this just to the REMAC's attention, just as a discussion point, even though there's not been any formal proposed changes to our protocol, but just wanted to have this as a discussion at large for our region.
So there definitely are some places where there is proposed legislation to prohibit use of ketamine, if I'm not mistaken.
That's correct, David, for sure.
I think what Matt was suggesting is that was more reactionary than based on good evidence.
Right, and I guess the other part of that, Joe, is that the Denver group put together a statement, which I think is Googleable, that basically cites some of the support for the use of ketamine in the pre-hospital setting. I'm not suggesting that this group necessarily takes a position, but just keep in mind that our hand might be forced at some point. Should there be an event occur in the city, or should there just be a movement in response to the upcoming trial to remove this as a valuable tool? So I don't know whether it's worth the time or if it's the prerogative of this body to write such a statement. But I think it sounds like many of the people who sit on this body agree that when used appropriately, it's a valuable tool. And I just wonder if we want to generate a document, not yet for publication, stating our consensus.
Dr. Kostoko, I believe you have your hand raised.
Yeah, I think that's a great idea that Matt brought up, just to have something prepared. But personally, I just wanted to comment that we use a lot of medications that have potentially dangerous side effects. And I think that as long as we're making sure our protocols have the right doses and the right indications, ketamine is a really important tool with a very favorable side effect profile in many cases when we can't use other sedatives. So I think it's really important to keep it in our formulary. I don't know the specifics of the case. I don't want to quote it, but I believed that there were multiple doses and it was a pretty high ultimate dose there. But that's my 2 cents.
All right, Matt, if you could maybe, if you want to draft some language, and we'll have it for the next meeting to review and have it in case we want to move forward with it.
You got it.
Thank you so much.
And I think that Dr. Bodick sent us in the link, in the chat, a link to the American Psychiatry Association.
Yeah, I sent a PDF
statement.
of the actual position statement, and you'll see there that the long language is strongly against diagnosis of excited delirium and the use by law enforcement. And there is a statement at the end about appropriate use of ketamine being okay and accepted. And I also put a link to a news article that has a little bit of the strong language from the psychiatry side.
I think that maybe when we write this document, we have to differentiate between law enforcement and EMS, because one is not the other, and perhaps for the correct indication for EMS, this is a valuable tool, and not for means of law enforcement. I don't think that
Right.
anybody,
I mean, David, one of the pitfalls of the case in Aurora was, around certainly some things that are preventable by education. This was a relatively young person who was 15, who got an appropriate but relatively high dose of ketamine, who was prone and handcuffed when they received the medication. So, I mean, there are a number of factors that contributed to the outcome there. So I think that part of the protocolization of this and part of the support, should we choose to support it, obviously is making a very strong statement against the appropriate education for its use, and then obviously patient positioning and so forth.
Excellent.
Okay.
Dr. Benoit, anything else?
Yes. So Matt, well, maybe if you draft something and submit it, we would be able to review it and decide. Any further discussion? Anything further from the protocol committee, Pam?
Nothing else further from the.
I'm sorry,
somebody read the psychiatric statement that was sent out, and I think we already meet this. What they're really against is, and I'll quote it directly: protocol should allow use of these medications only for treatment purposes in medically appropriate situations, and should explicitly bar their use to achieve incapacitation solely for law enforcement purposes. And our protocol already says that we only sedate people who are an active threat to themselves or others. I think our protocols are consistent with this statement. And we also just got rid of this term excited delirium, which is one of our other recommendations.
I don't think you necessarily need to make any position statement on this, okay, for the reasons just mentioned.
Okay. David and Pam, anything else from protocol?
Nothing else from protocol. Our next meeting is on October 8th at 10 a.m.
Thank you.
Thank you. I think
David,
that just
anything else
adjourns
for medical
the
standards?
medical standards. Nope, I think we're done with medical standards.
So, Marie, if you could put the REMAC agenda back up, please. I think we're winding down. I see that Joe Ranieri is back on, and I know that Mike was here. I don't know if he still is, but I'll let Joe present the QA stuff. But before I do that, I would just like to grab everybody's attention for 1 second, and I know that Marie wanted to say a few words. 2 days ago, we lost one of our paramedics in the region to suicide. Her name was Rebecca Solomon. She was a paramedic at Maimonides. I think that, we have talked about making a push for mental health awareness in the region, and I know Marie wants to say a few words about that. Before we do that, I'd like to ask for a moment of silence for Rebecca. Thank you. Marie?
Hi, I just wanted to take, I hate to say this as an opportunity, but we have a mental health team that is formed. We are training. We did our first training in August. Our second training is starting this Sunday, and it's in critical incident stress management. Our team will ultimately have 125 members, 25 of whom we hope to have as licensed mental health professionals. We're pulling from every agency in the city, fire department, privates, volunteers. The classes are all free. We have a clinical coordinator. We're getting a hotline so that we can have this information out there for every agency. We've already offered assistance to the Maimonides garage. They are understandably really upset and stressed out at this point, but many of our providers are experiencing emotional difficulties and are troubled. So we want to use our training to not just take care of them when they're in crisis and refer them. We want to educate EMS providers on how to interact not just with patients, but with each other, and to recognize the signs and symptoms of depression and anything leading to the possibility of suicide. If anyone here, any of the physicians are interested in taking our courses, I certainly would like Dr. Bodick, going to be reaching out to you also to work with us, and our clinical coordinator, who is a licensed social worker, to help us with our team. We're putting together our operation policies and our response protocols. So I'll be giving you more information as this team becomes more active.
Marie,
Yes?
as chair of REMSCO, I was wondering whether it may not be appropriate for there to be a joint tag or task force, I'd rather call it, between REMAC and REMSCO to start offering, not after the event, but as you say, before the event, training our providers. Unfortunately, Rebecca is not the first one in recent months, and members of all stripes are really under stress. There's a lot of stress going on, and we don't even know for sure. I mean, I don't know for sure why Rebecca took her own life. I don't know if it had to do with on-the-job training, but whatever it is, there is stress just being a paramedic or an EMT. And I think it would be very useful if we had, maybe Dr. Bolden would like to actually chair that. I mean, I'm sure she's very busy, but to chair such a task force joining the REMAC, the physicians, and the REMSCO, who are responsible for the operation, to put this into effect. And I know, Marie, you've been putting a tremendous amount of work on this, which is invaluable. We should all be very appreciative of it. And I think it needs to be incorporated in this as well. And possibly even training and testing. Training should possibly put a module together about self-help. and how to go about dealing with stress, and more importantly, how to reach out, not to be embarrassed about reaching out. Many people are depressed. We don't even know that they're depressed. And as everyone described Rebecca as a happy, go lucky, smiling, and no one could predict that whatever the reason was, that she did what she did. So I really think it's very important that we target this. We have a responsibility not only to the public who we serve, but we have a real responsibility to the EMTs and the paramedics that we're here for. So I would like to propose that, Dr. Schenker, I hope you would agree. Perhaps offline, we can talk to Dr. Bowden if she's willing to share that and put something together.
Wholeheartedly.
Thank
We
you.
appreciate all the help.
Thank you.
And one of the goals of the team is to have outreach to all the agencies, to have people go and present and teach at an agency level so that the leadership and the educators at each agency have understand that they have a resource out there. There are lots of resources. It's just that people don't know about them. And that's what we need to share with them.
Thank you, Marie. Okay, Joe, let's finish up with the QA committee report, and then I think we'll wrap things up.
I just say one thing. I do
Go ahead,
appreciate,
Nathan.
this terrible event, and that we're all trying to help. I do think we have to talk about as a committee how we're going to help before endorsing things like critical incident stress management. The evidence is pretty clear that offering people access to licensed professionals such as social workers or psychiatrists helps, but training lay people in critical incident stress management has never been shown to be helpful, and some of the evidence suggests that it is actually harmful. So before we start going down this road of a specific training of CISM for lay people, as a committee of physicians, if we're going to endorse something like this, I think we have to look honestly at the evidence and make a decision on what we can offer so that we can offer things that are helpful, and not just train a bunch of people in CISM.
Respectfully, we were under the guidance of the New York State Office of Mental Health when these courses were selected. So
Okay,
that's where we're getting our direction from.
If it's something that the REMAC is doing, then we should have a discussion before doing it.
Well, it's already being done.
So I think that there is I think you brought up a good point, and now that we have Dr. Bodick on board, we should have a conversation about this. We should figure out what the right things to do are, and not just follow the state. I think that there is a role for having someone to talk to, and maybe that's the role for CISM, but licensed, therapists, licensed people who can really help people who are in need, I think is a very important component. So let's take that offline. We'll continue this discussion. Anybody who's interested in participating, please let Marie know, and we will definitely include you in the discussion. That said, I wanted us to try to get us done. Let's go to Joe with the QA report, and we'll move forward.
All right. Thank you, Dr. Schenker. So the QA committee last met in August. We are currently in the midst of our 2021 quality improvement project, which I would like to present on at this moment. We just got done doing a public forum on that related to that project, as well as doing a lot of regional outreach. So I'm just going to share my screen and present on some of the pieces of that project now for the committee.
At the beginning or the end?
Yeah, we're getting there, Yedidia.
Final thoughts.
Yes, and to present on this, our final thoughts. Let's see here. There we go. Sorry. All right, so our 2021 quality improvement project was an outgrowth of what we started in 2018 and 2019 looking at ways to improve stroke and STEMI care in the region. Some of the projects initiated during that time period included the development of our First Watch project for regional dashboards, the development of the stroke protocol for transportation of LVO stroke patients and the assessment for that, right? Our NYC SLAMS assessment. So this project is an outgrowth of that to start seeing some of the some additional ways we continue to improve that care throughout the region. So for this project, we looked at the New York City data, and we identified 3 aims in which there was room for significant improvement within the region. One of those included reducing average on-scene time for suspected stroke patients by 10%. Right, the current average on-scene time for the region is about 23 minutes and 50 seconds. So we're looking to get a 10% reduction in that. As we all know, right, as we decrease on-scene time for stroke, right, we get that patient to definitive care. The next piece is increasing the percentage of stroke calls in which a blood glucose is obtained. So we found pretty good compliance on this throughout the region, as we know that this became the standard of care within the last couple of years. So we found that currently that occurs within about 79% of stroke potential stroke calls. We want to try to get that up to about 85%, which is what the national standard is. And then finally, for potential atraumatic stress STEMI patients, we want to increase the percentage of those patients that receive a ECG within 10 minutes of patient contact, right? So again, this is all going towards meeting best practices, right? We want to quickly identify that the STEMI is occurring so that the patient can be transported appropriately, the hospital notification can be made faster, and we made that an aim to increase the percentage for that. Right, so as I said, right, our BGL obtainment, right, became the standard of care within the region a couple of years ago. So we're trying to improve compliance on that. And as I said before, right, we are seeking to achieve 85% of patients to receive the ECG within 10 minutes of EMS contact. That's a national benchmark. And we already talked about the definitive care. So for this quality improvement project, we gathered data from a couple of different means. First is we started utilizing our First Watch dashboards that the committee worked very closely hand in hand with the American Heart Association and the fire department and the First Watch company itself to develop. It allowed us to get some good dashboards together and see a good overview data of how the system is performing, both as a snapshot and working on getting that done over time as well. So it does include nearly all 911 participating agencies submitting data. So it does give us a nice, good sample of what's occurring within the region. We are, so this is some of the data that we're looking at. So another source of data is pulling data from the state EMS elite site where all the regional PCRs go. So that allows us to get breakouts for not just 911, but region-wide to see if there's any significant differences there, because obviously this is a regional project. So we don't want to just look at that. So in addition to that, we conducted a quality improvement project survey. We sent that out. We had about a 3-week information collection period. And that was that survey focused on getting qualitative data, right? We're using First Watch and our PCR data to get our quantitative information. We utilized 2 forums to get some qualitative data and get feedback from the region. And that included the survey, as well as conducting a quality improvement regional forum. So for the survey, we sent out questions in regards to related to these aims, right? If providers had ran into any could identify obstacles that prevented them from obtaining a blood glucose measurement on a potential stroke patient, right? What were some obstacles that may prevent them from doing that? And we actually solicited suggestions from them in ways that they felt that we could increase adherence to that. So we did that for the survey. And then in the regional forum, we actually got a number of QA coordinators and ALS coordinators from the region to participate in a discussion type format. That was held at the beginning of September. That was a very good discussion. So we're still tabulating the data from some of these pieces, but we do have some broad overview things to present. So this was the survey responses. So we had a good breakout of paramedics, EMTs, and some physician participation, and a pretty good breakout between administrators and field providers. Again, along with some agency medical director participation as well. So some of the things that came about from the survey data is a couple of themes related to obtainment of blood glucose. Some obstacles included just in lack of provider training, right? Understanding when they need to be obtaining a blood glucose, and an additional focus on that on the agency level, encouragement on that. Some agencies, some respondents reported that their agency actually did not currently offer blood glucose, right? So they're on a regional level, that is something that we could assist agencies in getting. And then the condition of the patient, and then additional equipment failure and training. So again, here's some of our suggestions. So training is usually at the top of the list for these types of things. Some protocol changes to further stress the necessity for BGL obtainment, and regionally working to ensure that blood glucose is something that all the agencies have available to their providers, and integrating some of that in the EPCR fields, making some mandatory rules around obtaining blood glucose as well. So that's just one example. We have some driver diagrams that I'd like to present as well. Just give me one moment, please. I'm just going to stop my share for a moment because it's for some reason it's giving me difficulties. All right, so this driver diagram looks at some of the primary drivers and secondary drivers of another one of our aims, right, which is the quick assessment of ECG within 10 minutes of patient contact. Just give me one moment, please. Sorry, that was Dr. Redlener. He's going to be hopping back on shortly, so he can present his final thoughts on all of this. So some of the drivers that we saw in terms of what would delay some of our crews in the field in terms of obtaining an ECG quickly, right? So we had some patient factors, right? Religious concerns, right? Patients being uncomfortable with being assessed by a provider of the opposite sex, patient agitation, the crowded room, but also the condition of the patient, right? Their skin condition in particular, some of those factors could cause challenges in terms of getting the leads on. Number of providers brought up crew efficiency, right? Making sure that you have your monitor available and it's already set up to quickly get the get the leads on. Further integration of utilizing a BLS unit that's on scene, right, and using all of your resources efficiently, right? So not just having the ALS crew show up on site and then the BLS crew just kind of stands to the side, right? Everybody is doing a piece of it, a piece of the work, so that there's no duplication of effort. And then it was in particular to a number of providers brought up repeating assessments. So BLS will do an assessment on patient, present it to ALS, they'll do a repeat assessment for like patient history and things like that. And then we just had things such as equipment and transport and delays in telemetry. And then finally, this is the one for reducing stroke, and then we'll wrap it up with this driver diagram. So again, we had some crew efficiency challenges, right? Obviously, getting to the patient, approach to communicating with the patient, right? So that we're eliciting the information that we need. A number of providers reported delays in terms of utilizing telemetry to make stroke notifications and getting.
So I don't think we see the diagram you're talking about.
We
see the ECG diagram.
Thank you for bringing that up. I'm sorry, I may have to update my share on that. Let me just see if I do a share update. All right, so do we see that now? It should indicate for stroke on scene times driver diagram. Thank you. Thank you, Dr. Benelli. So Cruz brought up challenges with the telemetry process, going through all those steps, right? They indicated lengthened on scene times. The availability of ALS was one. Again, crew efficiency, making sure that each crew member is working together to collect the information so one crew member is doing the stroke assessment, the other crew member is collecting the patient medications and history and vitals and things like that. Right, so not one crew member is standing, the other crew member is assessing. Everybody's doing a job. And then we had some patient factors, language barriers, accessing to the patient, sometimes with working with the family members, particularly for patients that have such language barriers, or again, dealing with those patients that were not comfortable with the provider. So maybe regionally developing some better communication best practices to increase the comfort level of patients with allowing providers to do the assessments. So there's still a lot of work to do on this project. Dr. Redliner, I believe you are on. I just presented the outline of the project as well as our driver diagrams, if you wanted to give additional thoughts.
Yeah, perfect. Thanks, Joe. I apologize to everybody for being pulled away. I think that I think we've had some great success thanks to Joe and Rob Zeitz and a number of members of the team for organizing a lot of this. But we've gotten a lot of engagement from the EMS community to put these ideas together. The point now is to utilize these ideas to drive our data, to drive our practice, to improve our aims, and utilize the tools that we've developed over the last few years, namely the First Watch dashboard, and monitor that dashboard as we implement some of these ideas. And again, I think Joe probably mentioned, but engaging the education committee and putting together some options for agencies to use to improve these specific items, and then coming back together to evaluate how we're doing, and again, continuing the cycle of improvement. So thanks, again, thanks to everyone. I apologize for my bad connection and my delay. So, but we hope to hear from you. If there's anybody who's got any, wants to give input, I'd love to have it from you all. But I think that's the idea, is to put together this change package to drive improvement in our region.
All right, thank you, both of you. That was very well presented. Thank you, Mike, for hopping back on and closing us out. Does anybody have any questions about the QA project, about anything we're talking about to wrap up? Okay. Well, hearing no questions, I will entertain a motion to adjourn. Not even a motion to adjourn. All right.
Before we adjourn, I just have a
Motion to adjourn.
Can I ask one question first?
Sure, Nathan, go ahead.
What's the next step with this critical incident stress management? Because we need to look at the evidence and make a decision. We shouldn't be forced into this by the state. It's clearly a harmful intervention. I'm happy to send the evidence there.
I have to tell you right now, we had a grant, it's already started, and we are doing critical incident stress. So if REMAC does not.
Because someone gave us money doesn't mean we should do something that's
guys,
best for our members.
We should use the grant for.
Guys, we're going to take this off this discussion. We're going to have a separate discussion with the specialists in this field and decide what is the best course of action. Nathan, I strongly ask you to participate in those discussions.
That's my point. What's the next step? Where can we actually discuss this?
So if you could send an email to Marie that you're interested, Yadidja, myself, and Dr. Bodick will get together. We'll set a time for this meeting, and it will just keep your eyes open. It'll be within the next week or two, hopefully, and we will have this discussion and be able to report on it at the next REMAC meeting.
Okay, I'll put together a review of the evidence and send it out to everyone. So you can hear yourself.
Joe, can I just say one word, please?
Sure, David, go ahead.
Yeah, so I think we all are on the same page that we want to help our providers. And we just have to decide how it is best to do that. And if we have a grant and we have money, we need to put the money in the appropriate direction. And if we feel that critical incident management, incident stress management is not the right tool, then we should look on utilizing the grant towards the appropriate tool that will help. And I will let Mira and everyone else, given input to decide how to proceed.
I agree. Anyone else? All right, we made a motion to adjourn. The next meeting, Marie?
I'm sorry, what?
When is the next meeting?
I do not have my calendar in front of me. I'm sorry.
All right, we will.
Joe, can I just mention the
I'm
conference?
sorry, go ahead.
No worries, no worries. Hey everyone, apologies for not being to attend the whole meeting today, but I did want to just quickly mention that we're having a really great conference next Friday. It's our third time doing this, the New York Mobile Integrated Healthcare Conference. We have a ton of great speakers from the region: Brad Kaufman, Dave Prezant, Hannon Cohen, John Washko, and from outside the region, we've got Matt Savatsky and some leaders of some national organizations presenting. So if you can join us, I put the link in the chat. It should be a great conference, and please do spread the word. It's available for CME credit for your providers. Thanks.
Okay. Thank you, everybody, and have a great night.
Thank you.
Have a good night, everyone.